Okay, thank you. So I'm going to be talking about bacterial STIs, specifically GC and chlamydia, and at the end on strategies to prevent GC and chlamydia with doxypep and syphilis. I mean, it prevents syphilis too, but I understand you had your syphilis talk a month ago. And if you have any questions on syphilis, I'm happy to share my knowledge on it. Okay, so this is the objectives, basically to understand a little bit about the epidemiology in the United States of chlamydia and gonorrhea, and then what's the clinical presentation, diagnosis, and then treatment and prevention. So I always put this slide in because it is important to understand that the fact that we're seeing a rise in STIs, although it has plateaued in the last year, is because this is endemic. And other factors like structural, social, and behavioral factors are driving these epidemics and making them difficult to control. I think, give me a second. I have the wrong presentation. I mean, it's the same topic, but it's a different one. I'm going to have to stop sharing. I apologize for that. Okay. I hope it works now. I think it's this one. Can you see it?
We can.
Okay. Yeah. I noticed there were some things that were missing. That's weird. Okay, so this slide, these are most of the epi slides are from CDC website. Just to give you an idea that in 2023 we had over 2 million cases of STIs, in which chlamydia is the most frequent one. You can see here in this graph, followed by gonorrhea, and then we have syphilis. And when we look at what's happened with gonorrhea and chlamydia over time, you can see that in the 1940s, there was a spike. That was lack of treatments. Then treatments came about, it declined. Then it starts going up again and declines basically around the AIDS epidemic, because people, were realizing that to prevent HIV, they had to increase protection on their sexual encounters, and that also helped to decrease other infections. Like we're using mass COVID and he didn't have more influenza. And then it came down, and then from 2011 to now, we saw a big spike. And that's, in my opinion, and also other people, is combining this with the substance use disorder epidemic. It made things a little bit worse. And you can see the chlamydia on the right-hand side rates, how they have been increasing almost steadily with just a little blip in the last 30 years or 40 years. When you look at the rates by gender, so gonorrhea is much more frequently diagnosed or reported, at least in men, and chlamydia is more frequently diagnosed and reported in women. And what people believe is that, first, gonorrhea is more symptomatic in men than in women. So men are more prone to go and see a provider if they're having a urethral discharge than women, which may be completely asymptomatic. And then for chlamydia, I think that we test women, or we should be testing women that are under 25 systematically every year, but we're not testing men every year systematically. I think that's a mistake, but it's not recommended to test men because it's apparently not cost effective. That does not mean that men are not cost effective. It's just chlamydia, and testing chlamydia for men is not cost effective. And then we also see a lot of disparities regarding ethnicity that happens with hepatitis C and HIV. So this is not a surprise, and that's related to social determinants of health, but also could be some data limitations on not reporting ethnicity which actually undermines the statistics. It could, or underestimates these numbers that could be even worse than what we think they are. And this is just showing the same disparities for the STIs without, looking at cases compared to rates, basically. And AIAN have second rates after African Americans in the United States. So this is also interesting when you look at gonorrhea and look at who's getting infected based on sexual behavior. So in gonorrhea, men who have sex with men have the highest rates, and then men who have sex with women, and women are on the least, on the third tier of rates. But I also believe that men who have sex with men in general, those who are engaged in care, will consult more frequently when they have symptoms, and females do not consult as frequently as they do. Also, men who have sex with men get tested more frequently because many of them, not as much as we wish, but many of them are on HIV PrEP or some form of, every 3 months follow-up in which they get STI testing, and not as many women are in HIV PrEP or those more comprehensive STI healthcare engagements. Now, when we look at chlamydia, then things change a little bit. Men who have sex with women have the highest percentage rates, and then comes women, and finally men. And it varies a little bit depending on what age group you're looking at. But again, I believe here that women are getting tested more frequently for chlamydia in particular, although usually they get a GC test also because they are being screened, and men are not being systematically screened in general. I mean, when we started with these programs, it was testing only for chlamydia, but now most of the tests include GC and chlamydia. I know you've had a talk about this. I'm pretty sure, maybe confused about taking a sexual history. I'm not going to take a deep dive, but it is critical to obtain a clear, good sexual history, or else you will not know what may be affecting your patient or what testing needs to be done. So there's some general questions, like identity question, ask them about their pronouns, what gender they identify with, what sex they were giving at birth, just to make sure you understand the situation and the risk of that patient, excuse me, for different infections. Then what is the terminology that the patient prefers to use, and critically, excuse me, the sexual activity in the last 12 months. Because if someone tells you I have not had any sex in the last 12 months, does not mean they do not need to be screened, because they could have acquired syphilis 2 years ago, for all you know. But at least you don't have to get into a very aggressive screening mode based on the history. But the most important thing is creating a respectful environment, and it's not easy to take a sexual history, and I don't think you can take it on the fly. Like when a patient's coming in for their diabetes checkup or whatever, if you need to focus on their diabetes, I think you need to, if possible, generate a visit just to talk about their sexual health, because that could take the whole visit. But maybe if you're in a rush, at least a few questions may be important, like, have you had sex in the last 12 months at all? And if they say yes, how many partners do you have, and what protection do you use? Maybe just drilling it down to 2 or 3 questions when you're in a rush. But I think a comprehensive sexual history, it's important, and also it'll make it easier for follow-up, because once you've taken a comprehensive sexual history, on the follow-up, you can just ask, has anything changed since we've discussed this in the past, and it makes it easier to monitor. So the 5 Ps that the CDC recommends, some people are for it. Some practitioners say it's not enough. Some practitioners say it's too long. But anyways, it's asking about partners, gender identity of the partners, the number, and if they have a stable partner or not, practices, type of sexual contact. Do they have oral sex? Do they have anal sex? Do they have vaginal sex? Do they have both, a combination of them? That's important to decide, what are you going to test? Are you going to test the throat, the anal area, the urine, the vagina, or all of them. And sometimes when you don't have to ask time to ask those questions, you better test all of them to make sure that you don't miss anything. Of course, pregnancy is important, not only if they're pregnant or not, but do they intend to get pregnant? Is it important for them to be, are they searching for a pregnancy? You may not want to put someone on doxypep if they're searching for a pregnancy, for example, if they qualify for doxypep. Previous STIs, that gives you a hint of the protection that are actually engaging in, because they may say, yeah, I use condoms all the time, but you have several episodes of chlamydia or GC or syphilis in the past. That means that that protection is either not being done properly or not working for them in some way or form. The protection, as I mentioned, is also important to discuss, because that's the only way you can recommend post-exposure prophylaxis for STIs or pre-exposure prophylaxis for HIV, for example. So on the right, I'm not going to go over this list on the right, don't worry, but I think it's a very good list of different situations regarding gender and situations of the patients, like if they're pregnant or not, are they in a correctional facility or not, and when they should be screened for STIs. But at the end of the day, it boils down to a comprehensive history, taking into account all the information you got from the sexual history, and also what are they willing to do to help themselves in the future. And some people may say, I'm not going to use condoms, period. So that's out of the question, and you have to look for other solutions for that patient. So the clinical presentation, I just first want to say that the majority of chlamydia and gonorrhea infections are asymptomatic, meaning the patient does not have symptoms. And that's why it's important to screen them, even if they don't have symptoms. If they are having sex that is not protected with multiple partners. I mean, if they have one stable partner who has been tested and they're negative, you don't have to screen them. But if they have had more than one partner or not using protection, they should be screened. So depending on the anatomical site, it's the different symptoms. If it's in the anal area, it could be from pruritus to pain, discharge, or tenesmus, and bleeding. So it could be severe. And the genital symptoms can go from nothing to, in a female, mucopurulent discharge or dysuria and frequency. A lot of times these are mistaken by providers for UTIs, and they're treated as UTIs and they don't get better or they get worse. So make sure that it's not a UTI and it is a UTI and it is not a chlamydia or gonococcal infection of the genital tract. And for males, the typical one is the urethral discharge, the most common one. But sometimes if they present with complications, it could be testicular pain or swelling or other symptoms. Or these bugs, chlamydia and gonorrhea, are frequently found in the oropharynx, but they rarely are symptomatic. And when they are symptomatic, it's usually gonorrhea. Chlamydia is usually asymptomatic. So if you don't test the throat, if you don't swab the throat, you're not going to find it. Reactive arthritis is not very common. I've seen it a handful of times, but it can happen as a post-infectious syndrome with both gonorrhea and chlamydia. And then pelvic inflammatory disease is the scary one that you really want to detect quickly, because that can lead to a lot of complications, including infertility in the female, and if it's not treated properly, sepsis and death. And perihepatitis is a rare syndrome. I don't think I've ever seen this, but it is reported all the time. And if you're taking your boards, you better know it. And this is apparently the GC can migrate to the liver from the fallopian tubes and hit the liver and cause like acute hepatitis syndrome. So it is important to differentiate complicated from uncomplicated infections. And the easy way to remember is uncomplicated is when it is limited to the mucous membrane. It is limited to the vagina. It is limited to the urethra, to the penis, to the anal area. It's not spreading above that. So it involves urogenital infections, rectal and pharyngeal infections. But when it goes up to the uterus, fallopian tubes, and the female, or to the epididymis or testicle, then those are complicated infections. And when they get really bad, it could be disseminated in the case of gonococcal infections. So other things beyond being complicated or not, you need to consider if the patient's pregnant or not, if they're HIV co-infected, and if this is occurring at in a very young child, because that could have some legal implications of abuse. And on the right, this is just a beautiful slide of gonococcus invading leukocytes, PMNs, and this is a gram stain. And this is the way we used to diagnose it in the old times before we had the nuclear tests. So diagnosis is, of course, clinical assessment, get a good thorough history just to make sure if the patient is symptomatic that this is a complicated or uncomplicated infection. Obtain the proper specimens. And like I mentioned, the patient mentions they're having anal sex, vaginal sex, oral sex, you need to swab all orifices. If they only confirm one side of that's enough. But if you don't know or you haven't asked properly, swabbing all three sides is probably better. And NAT or nuclear assays are the preferred test that we use today, specifically for chlamydia and gonorrhea. And I'll go over them a little bit more. So NAT is the gold standard. It's highly sensitive for both chlamydia and gonorrhea. It's very specific if you do it properly. And what do I mean by this? If you test someone today and you treat them and you retest them in a week, the test may be positive. It doesn't mean the infection is there, because these tests are so sensitive that it will pick up dead DNA or dead bugs or DNA from dead bugs and call it a positive test. So that would be a false positive. So you need to know when to retest. Make sure the specimens are well obtained. Usually patients take better specimens, obtain better specimens than we do. So self-swabbing is the way to go if you can do that in your office. Just give the swabs to the patient. There are educational pamphlets you can give them on how to obtain the oral, the anal, the vaginal, and the urine specimen. And the patient can go to the bathroom and collect all of them and then give them to you. Saves you time, and it makes for a better specimen collection. But at the end of the day, it's what the patient prefers. The problem with the NAT test is that it doesn't give you sensitivity. So in the past, when you order a gonorrhea culture, you would get the culture back with saying, well, this bug is sensitive to this, or that, and you can guide treatment. Today, resistance testing is only done on Sentinel laboratories that are part of the surveillance system in the United States. And with the recent things that have happened in the government, probably we will have less of these Sentinel laboratories around. So that's not good. So in the past, like I mentioned, we used to do a gram stain of the urethral discharge or a gram stain of the cervical discharge, and we find this, bingo, that's gonorrhea, and we would treat it. This is not used a lot today. You can do it if you want to and ask your lab to do it, but it's not a common practice. NAT test is what we do usually. So when we compare, this is just a table comparing NAT with culture, with gram stain, and with point of care test. And the advantages of NAT is that it's very sensitive. You can do it now. You can do it on all swabs. In the past, we had problems because it wasn't FDA approved for throat or anal, but now it is since 5 years ago. So we can do all three tests. Now use different swabs. Don't swab all three orifices with one swab. Just a tip. The only disadvantage of NAT is that you don't have antimicrobial susceptibilities. Cultures, we hardly do them anymore. They're difficult to do, complex, they take a lot of time, but that's the only way you'll get sensitivities if you need them. Gram stain is okay if you're in the field and you have a microscope. That's easy to do, a gram stain, but in your clinics, you don't need that. And there are point of care tests now for chlamydia and gonorrhea. They're not as sensitive as the other ones, but they're pretty sensitive, and you have the results immediately. So you're able to, most of the time, avoid unnecessary treatments. So the guidelines changed in 2021, and in the past, we used to give chlamydia infections 1 gram of azithromycin. So they decided not to do that because there's more resistance with macrolides. So the treatment is doxycycline, 100 milligrams orally twice a day for 7 days for chlamydia, and only azithromycin is, if for whatever reason you cannot use doxy, then you can use that, but not the preferred treatment. For pregnant women, azithromycin is the drug of choice. Amoxicillin is your backup. For LVG, lymphogranuloma venereum, that's caused by chlamydia. And when you're doing a chlamydia test with NAT, it won't tell you it's LVG. It just tells you it's chlamydia. So one tip is if you're seeing a man have sex with men and problem is in the anal area, you may want to request LVG testing, or you may just go ahead and treat it for 21 days with doxycycline. So it does require more prolonged treatment. And the baby ophthalmia neonatorum, which is the conjunctivitis of the baby, it's erythromycin. The treatment is erythromycin. So for gonorrhea, also the dose has changed. Uncomplicated infections is 500 milligrams IM in a single dose, as long as the patient weighs less than 150 kilograms. If they weigh more than that, it's 1 gram what you should give. For disseminated infection that you hopefully will not run into this in the clinic, but you may run it in the hospital, it's ceftriaxone IV, 1 gram per day until the patient gets better. For pharyngeal infections, it's the same dose of ceftriaxone, that doesn't change. And for conjunctivitis, this is an adult with conjunctivitis, not a neonate. You give a higher dose of ceftriaxone. Now, we are seeing an increased resistance to gonococcus gonorrhea. And to prevent this, the best way is just to follow the guidelines, to treat everybody appropriately. Do not give them subtherapeutic dosing of the ceftriaxone, and do not use other treatments that are not first line, like quinolones or cefixime, unless they're indicated for a particular reason. And only in a survey that was done before the 2021 guidelines, 20% of the people were not following the guidelines. And that's a lot. Usually, if you work in an STD clinic or in a reproductive health clinic, you tend to follow guidelines a little bit more. But my message to you is make sure you follow the guidelines, which I just mentioned. So recommendations for management and follow-up of patients with chlamydia. So first, they shouldn't have sex for at least 7 days. And if they have a partner, the partner should be treated at the same time, or else you're going to have a ping pong event of giving the chlamydia or the gonorrhea back and forth between them. Others recommend that not only 7 days, but that the symptoms need to be completely resolved before they re-engage in sex. You do not need to do test of cure, meaning repeat the test in 14 days, unless the patient's pregnant or unless they have a pharyngeal infection. Because the pharyngeal ones, the gonococcal I'm talking about, have higher failure rates, and there's a risk of being resistant. So unless it's pharyngeal or unless they're pregnant, you don't retest them. But if they are, 14 days after, you do another NAT test. Now, it is recommended that 3 months later, you retest the patient. That's not a test of cure. It's basically making sure the patient didn't get exposed again and got infected again, especially if they didn't follow the no sex guideline, or they've engaged in, no sex for 7 days after during treatment, or they are continuing to engage in unprotected sex. And pregnant females should be tested. It's 2 to 4 weeks after the end of treatment. If you do it 2 weeks after, the risk is that you may have a false positive. But if it's negative, it's negative. So that's good. And the other important thing, anybody who has a gonorrhea or a chlamydia infection, especially gonorrhea, should be tested for HIV and syphilis and offered HIV PrEP or doxy-PEP. If they qualify for it. And I'll go over the indications in a minute. So let's talk a little bit. Okay, are there any questions so far? Let me look.
You did have one in the chat.
Can you read it? Because I can't see the chat.
If NAT is highly sensitive and picks up dead bacterial matter, I guess, what would be the indications for retesting?
So the indications for yes, that's a great question. And I partially answered it on the last few slides. You would retest if the patient does not improve their symptoms. But in this case, So okay, for the first, okay, let's step back. First, if someone's not improving, you have to ask them if they took their treatment. Remember that in the past, we would give them the azithromycin in the office. It was like observed therapy. But now you're giving them a prescription for 7 days of doxycycline for chlamydia. So first ask them, did you actually take your treatment? Then maybe if they say yes, ask them if their partners got treated and if they had sex within those 7 days, because that may be the problem. If it is gonorrhea, if their symptoms are not improving, I would be concerned about resistant gonorrhea. And then the test, you can do a culture at any time. You don't have to wait 2 weeks to do a culture. So you could swab the place that's still inflamed, if it's the urethra in a male or the cervix in a female or wherever the infection was, or the throat. And then you order a culture for GC and they will do the sensitivity testing. If it's not, let's say the patient tells you, no, I'm taking, everything's fine. The patient's recovering well, took the treatment, complied with your recommendations, then you don't test them until 3 months later, just to make sure that they did not get exposed again. But if they're pregnant or if they had oral GC or chlamydia, then you test them 14 days later or 14 to 28. Does that answer the question?
Yes, in the chat we got yes. We're good.
Okay. Perfect. Thank you. Okay, so I'm sorry, let me go up. So doxypep came about, I think it's almost 2 years ago, but this was published in 2022. So what these investigators did, they did a randomized clinical study in which patients who were at high risk for acquiring STIs, the majority were men who had sex with men, if not all. They got single dose of 200 milligrams of doxycycline that were given within 72 hours of a condomless exposure. And that's what post-exposure prophylaxis is. Pre-exposure that we really don't use too much, although some patients automatically do it, it's to give just doxycycline every single day to prevent infections. So if a patient's having unprotected sex every single day, maybe PEP pre-exposure would be better than post-exposure. But the data is basically on post-exposure. So this was conducted in San Francisco and Seattle in an STI clinic. It targeted men who have sex with men and transgender women who were HIV negative and who were and the majority of these patients were on PrEP. And they gave them what I told you, doxycycline 200 milligrams within 72 hours of an unprotected sex exposure, condomless oral or anal sex. And the primary objective was to see what happened with the STIs. Well, they found that both cohorts, the HIV and the PrEP cohort, 74% reduction in chlamydia, 57% reduction in gonorrhea, and 77% reduction in syphilis cases. And if they were not the HIV cohort, the PrEP cohort, similar numbers. The caveat is this: there has been 4 studies done on this already, at least 4 randomized studies. And this one is the one that showed the highest rates of decreasing gonorrhea. The other one showed 30% decrease in gonorrhea because many of the gonococcus are not susceptible to doxycycline, and we don't expect them to be. But it's maybe on this population that was tested here, they had better, nicer gonococci running around. But in general, the impact is not so much on preventing gonorrhea, but on preventing syphilis. That's the main target, and chlamydia infections. And when you looked at this group, 87% of the patients had really good adherence. I mean, they took the medication as instructed, within 72 hours of the exposure. 54% were low frequency users. I mean, they had sex 10 times a month. And 16% were high frequency users. They took more than 20 doses a month. And the average amount of reported sex acts were 7.3 per month. On the right, you can see the columns of the impact. You can see the blue is gonorrhea. You can see that the blue, so it's a little bit blurred. So the first column is doxycycline PEP. The second column is standard of care. I mean, that was not the experimental arm, but the standard of care arm. And then the other one is doxy-PEP on the HIV cohort, and the first two columns on the PrEP cohort. And you can see that blue really doesn't change a lot. The major impacts that you see are in chlamydia and syphilis, and black is just all two STIs. They just combine both. So it does really help prevent chlamydia and syphilis, and a little bit gonorrhea, but not that much. So this was the first trial of doxy-PEP in cisgender women conducted in Kisumu, Kenya, and included 449 non-pregnant women that were on HIV PrEP, meaning they were at high risk. Actually, 1/3 of them had transactional sex, and the study failed. It didn't show an impact in women, but although the women did report that they were adherent when they tested their hair follicles for doxycycline, only 30% had doxycycline levels there. So they probably were not taking it. And they were, and that's why the other study, 87% of the people took the medication. Here's only 29%. So it doesn't mean that doxy will not work in women. It just means that in this study, they did not take it as instructed. And the prevalence of syphilis in that community was really low. So it was very difficult to have an impact on syphilis when the baseline prevalence was already low. So the CDC recommends a very strong recommendation for doxy-PEP on MSM and transgender women, especially if they had a history of an STI in the last 12 months. It's conditional approval if they do not have a history of an STI in the last 12 months, but they have increased risk. They have multiple partners and are having not protected sex. And they recommended against cisgender women and no recommendation on any other populations. But the bottom line is that you have to use your clinical judgment. So if you have a female that comes to you that is who's at risk of STIs or had an STI, I think you can discuss doxy-PEP with them and making sure they understand that we still don't have strong data, but it doesn't really make a lot of sense that it would not work because the doxycycline penetrates the mucosal vagina just fine. And, so you can give it to a female as long as you explain that it's not a CDC recommendation and we don't have a lot of data, but it does make sense to use it as long as they don't want to get pregnant. So that's the trick, because if they want to get pregnant, then the doxy would be a contraindication. So when you prescribe doxy-PEP, counsel about the benefits and harms, mention that it's been well documented in MSM and transgender women, use shared decision-making for all the other populations, including MSM and transgender women who do not have a bacterial STI diagnosed in the previous year. And the rest, same applies. Just use your clinical judgment. So this is just how you do it. If you have sex on Saturday, you have until Tuesday to take the PrEP. And if you have sex on Thursday, you have until Sunday to take that dose. Now, the earlier you take it, the better, the greater impact it'll probably have. So if they can use it as the morning after pill, that's probably the best thing to do. Now, if they're having sex frequently, they may be on doxy every single day until they don't have sex for a while, and then they don't have to take it anymore. But do not give more than 200 milligrams of doxy in 24 hours. So monitoring the patients, it's very similar. Like when you do HIV PrEP, you see them every 3 to 6 months, and you check them for STIs. Make sure they still need it. Make sure if they need it, that you give them enough doxy to take. If people are having sex, 15 days a month, they'll need more pills than someone who's having sex once a month. Then treat all the other STIs that pop up in the same way you would, regardless of doxy-PEP. And make sure you screen your patients to see if they need HIV PrEP or if they're HIV positive, if antiretroviral treatment is indicated. When they take the medication, there's a couple of tips. Take plenty of water. Do not lay down for 30 minutes because sometimes those pills get stuck in your esophagus and causes esophagitis, and that could be uncomfortable. Avoid antacids, especially the oral not the PPIs, but the Mylanta, those types of antacids, and multivitamins 2 hours or after taking PrEP. PEP, I'm sorry. And the risk is that they like the sun a lot. There is a risk of photosensitivity with doxycycline. Means you can have a harder skin burn. So make sure they're protected against that. And if they're planning to get pregnant or get pregnant, you need to stop it. The concerns are we generating bacterial resistance? And we may. And this is the first thing that they analyzed in this study. And you can see here that they showed a little bit of more resistant gonorrhea, which doesn't really matter because we're not going to treat it with doxy anyways. And there was more colonization. I mean, reduced colonization with Staph aureus, no increase in MRSA. And the risk of the other Neisseria that are not pathogenic is that if you make them resistant to doxy, they can transmit this resistance to other bacteria. Now, recent reports have shown that this is a little bit worse than what they show here. There's a little bit more resistance than what we think. But an interesting study showed that if you're not taking doxy-PEP and you're at risk of STIs, you're going to get STIs and you're going to get antimicrobial treatment for those STIs. So if you have one episode of chlamydia, you get 7 days of doxy no matter what. And maybe if you have gonorrhea, you get GC, you get ceftriaxone. So people who don't take this and are at high risk are probably taking more antibiotics if they're not on doxy-PEP than if they are on doxy-PEP. So summary, this is effective for prevention of STIs, but particularly syphilis and chlamydia. The CTEC definitely endorses it in men who have sex with men and transgender women who have a history of an STI. And for the rest, there's wiggle room to discuss it with the patient. There's more studies ongoing, and we need more data on resistance in the future. Here are some resources, and then I added some pamphlets that you can give to your patients, like this one here. What is doxy-PEP? When should you take it? Having these in your waiting area are helpful because patients can read it and maybe they can request it, even if they're coming for their diabetic toe checkup. And these are some resources for providers and for patients if you need them. And that is it. Happy to take any questions.